Good day everyone! Today, we will discuss an important topic in maternal health, diabetes mellitus as a pre-gestational condition. This is a condition where a woman already has diabetes before pregnancy, which can significantly impact both maternal and fetal health. So let's dive in.
What is diabetes mellitus? Diabetes mellitus is an endocrine disorder where the pancreas does not produce enough insulin to regulate blood glucose levels. During pregnancy, insulin requirements fluctuate. For the first trimester, insulin requirements decrease. In the second trimester, insulin requirements increase. And after placental delivery, insulin requirements decreases again. It is also important to note that women with diabetes are not ideal candidates for intrauterine devices or the IUDs or oral contraceptives due to potential complications.
There are four classifications of diabetes mellitus: type 1, type 2, impaired glucose homeostasis, and gestational diabetes. For type 1, it is previously called insulin-dependent diabetes mellitus. This condition occurs due to the destruction of pancreatic beta cells, leading to absolute insulin dependency. Type 2, or formerly known as non-insulin-dependent diabetes mellitus, results from insulin resistance combined with a deficiency in insulin production. Third, the impaired glucose homeostasis, a state between normal glucose metabolism and diabetes where the body struggles to use and secrete insulin properly.
Now that we've covered the classifications, let's highlight gestational diabetes. Gestational diabetes is a condition of abnormal glucose metabolism that arises during pregnancy, typically occurring between the 24th and 28th week. Women are at higher risk if they have obesity, age over 25 years, history of large babies greater than or equal to 10 pounds, history of unexplained fetal or perinatal loss, history of congenital anomalies in pregnancies, polycystic ovary syndrome, family history of diabetes, belonging to a higher risk ethnic population.
A woman with diabetes may experience the following symptoms: the 3 P's, polyuria, frequent urination, polydipsia, excessive thirst, and polyphagia, increased hunger. Pruritus, itching, weight loss, frequent UTIs, large fetus, or macrosomia.
Complications of diabetes mellitus can affect both the mother and the fetus. Maternal complications include pregnancy-induced hypertension or the PIH, increased risk of infections, polyhydramnios, and spontaneous abortion. On the other hand, fetal complications may involve macrosomia, congenital anomalies, stillbirth, and spontaneous miscarriage. Proper management and monitoring are essential to reduce this risk.
The diagnosis of diabetes mellitus involves several tests to assess glucose levels. The oral glucose challenge test, 50 grams glucose test, is performed during the first prenatal visit and repeated at 24 to 28 weeks of gestation. After consuming a 50 grams glucose load, a venous blood sample is taken 60 minutes later to determine glucose levels. Diabetes is confirmed if the fasting plasma glucose is 126 mg per deciliter or higher, or if the non-fasting plasma glucose is 200 mg per deciliter or higher.
If further evaluation is needed, the oral glucose tolerance test 100-gram glucose test is conducted between 32 to 34 weeks of gestation. If the 1-hour serum glucose level exceeds 140 mg/dL, the patient undergoes a 100-gram 3-hour fasting glucose tolerance test. Diabetes is diagnosed if 2 out of 4 blood samples are abnormal or if the fasting glucose level is above 95 mg/dL. The oral glucose challenge test in pregnancy follows the Carpenter and Constant criteria for diagnosing gestational diabetes. The fasting plasma glucose values are as follows: fasting greater than or equal to 95 mg/dL, 1 hour greater than or equal to 180 mg/dL, 2 hours greater than or equal to 155 mg/dL, 3 hours greater than or equal to 140 mg/dL. If 2 or more values exceeds the threshold, gestational diabetes is diagnosed. Other tests include serum alpha fetoprotein level, ultrasounds, creatinine clearance, NST, biophysical profile, HbA1c, ophthalmic examination, and urine culture.
The therapeutic management of diabetes mellitus in pregnancy primarily involves insulin therapy, blood glucose monitoring, and insulin pump therapy. For insulin therapy, a combination of short-acting insulin and intermediate-acting insulin is used. 2/3 of the total dose is given in the morning, while 1/3 is administered in the evening. Insulin is self-administered 30 minutes before meals, with a 2:1 ratio of intermediate to regular insulin in the morning and a 1:1 ratio before dinner. Oral hypoglycemic agents are not recommended during pregnancy as they cross the placenta and may be teratogenic to the fetus. Insulin is given subcutaneously with regular insulin drawn first before intermediate insulin when mixing. The recommended injection site is 2 inches away from the belly button. Lastly, insulin pump therapy is another option. Using an automatic pump about the size of an MP3 player, a syringe filled with regular insulin is placed inside the pump, with a small gauge needle connected to a thin polyethylene tube. The tubing is then implanted into the subcutaneous tissue of the thigh or abdomen, allowing for continuous insulin delivery.
As nurses, we play a vital role in managing diabetes in pregnant women by completing a thorough patient database, documenting test results, and educating both the patient and her family on nutrition and exercise. It is essential to emphasize continued evaluation, even postpartum, regardless of normal blood glucose levels. Encouraging regular exercise 3 to 4 times per week for 15 to 30 minutes, maintaining a heart rate of 130 to 180 beats per minute helps maintain health. Additionally, nurses must ensure the patient is prepared for intensive intrapartum assessments, advise contraception, and monitor blood pressure and lipid levels. Women with type 2 and type 1 diabetes should consult their OB before pregnancy for optimal health.
The signs and symptoms of hypoglycemia and hyperglycemia can present differently during pregnancy, with hypoglycemia being more common in the 2nd and 3rd months and hyperglycemia more frequent in the 6th month. Hypoglycemia is characterized by symptoms such as sweating, fatigue, pallor, cold and clammy skin, disorientation, irritability, hunger, nervousness, jaundice, headache, and shallow breathing with a normal pulse rate. Blood glucose levels are typically below 60 mg or DL.
On the other hand, hyperglycemia presents with flush, hot skin, dry mouth, excessive thirst, frequent urination, rapid, deep breathing with a fruity odor, blurred vision, depressed reflexes, and shallow breathing with a normal pulse rate. Recognizing these symptoms promptly is crucial for managing blood glucose levels and ensuring maternal and fetal well-being.
To sum it up, diabetes mellitus in pregnancy requires careful management to ensure both maternal and fetal well-being. By understanding the risk, diagnostic procedure, and treatment approaches, we can help ensure a healthy pregnancy and safe delivery for mothers with diabetes. As future nurses, it is our responsibility to provide education, support, and care for women facing this condition. Thank you for your time. We hope you found this discussion insightful.